Welcome back to our Clinical Explainer series, sourced straight from the Vestibular Physician Literature Review by Australian Dizziness Clinics. This is part 4, and we're zeroing in on the investigation strategy for labyrinthitis. Look, as clinicians, we all know that acute vestibulocochlear loss can feel incredibly chaotic when a patient first walks in the door. Our goal today is to replace that chaos with a highly structured, systematic, and protocol-driven algorithm.
The stakes here are massive, and this quote absolutely anchors our approach. We have to distinguish peripheral inflammatory disease from a devastating anterior-inferior cerebellar artery or ICA stroke. If a patient presents with sudden deafness, severe acute vertigo, and their bedside head impulse test is perfectly normal, you are looking at a central posterior fossa stroke until proven otherwise. Do not mask those symptoms with vestibular suppressants. You need an urgent MRI DWI right away.
To give you a quick map of where we're heading in this explainer, we'll start with branching scenarios, look at baseline tests, dive into imaging protocols, tackle the highly urgent post-meningitis pathway, and then wrap up with our key takeaways.
All right, Section 1, Branching Scenarios. Let's look at how a scenario-driven investigation strategy actually works in practice.
The big takeaway here is that the patient's initial presentation dictates exactly which branch of our investigation tree we need to go down. You have to start with an immediate otoscopic exam to build your framework. If the ear exam is normal, but they have acute vestibulocochlear loss, you're heading down the path of baseline testing and aggressive stroke exclusion. Now, if the ear exam is abnormal, say you see purulent acute otitis media or a cholestoma, you're dealing with a tympanogenic risk. That means urgent ENT surgical assessment and IV antibiotics right away to stop the spread through the round window. And finally, if there's a recent history of bacterial meningitis, well, that's an absolute emergency imaging pathway, which we'll break down in just a minute. Moving on to Section 2, Baseline Tests, specifically looking at audiometry and video head impulse testing. These two form the foundational pair of tests required for essentially all labyrinthitis presentations. Pure tone audiometry, or PTA, is absolutely mandatory. You really want to get this done within 48 hours of presentation if possible. Why? Well, first, it confirms we're actually dealing with a sensory neural pattern and not just a conductive loss from something in the middle ear. Second, it documents the acute severity and frequency configuration of the loss. But here is the kicker. It assesses speech discrimination. If a patient has decent pure tone thresholds but markedly impaired speech discrimination, that disproportionate loss points towards spiral ganglion neuron injury, basically retrocochlear pathology. Doing this early gives us our functional baseline, which sets the strict criteria for future cochlear implant eligibility if they don't recover. Oh, and don't forget, you have to follow up with serial audiometry at 6 and 12 weeks to document their response to corticosteroids and track that residual hearing trajectory. Because early, accurate mapping is so crucial, vHIT is our ultimate go-to tool in the acute setting. Video head impulse testing is fast, it's non-invasive, and you can do it right at the bedside. By measuring all 6 semicircular canals, vHIT objectively quantifies canal gain asymmetry. In acute viral labyrinthitis, it's typically going to show unilaterally reduced VOR gain across all 3 canals of the affected ear. This gives you a definitive map of the panvestibular involvement and confirms ipsilateral deafferentation, because you'll see those corrective saccades.
It's really worth contrasting this rapid vHIT approach with older caloric testing. Caloric testing is still a gold standard for documenting unilateral canal paresis, sure, but it requires prolonged water or air irrigation. Think about it. That is incredibly provocative and miserable for a patient who's already suffering from severe acute nausea and vomiting. And that's exactly why vHIT is the superior, preferred first-line tool when your patient is in acute distress. Caloric testing is mostly just reserved for subacute review phases or when you absolutely need medical legal documentation.
Next up is Section 3, Imaging Protocols, where we focus on ruling out mimics and confirming inflammation.
Ordering the wrong scan sequence can cost you vital diagnostic time, so let's break down exactly what each imaging modality does for us. MRI with gadolinium is your primary tool for confirming an inflammatory etiology. It beautifully visualizes labyrinthine enhancement on a post-contrast T1 scan, proving the breakdown of the blood-labyrinth barrier. Then you have your DWI MRI, which is your main weapon against vascular mimics. It's highly sensitive for posterior fossa strokes. Lastly, a CT of the temporal bone is your second-line structural check. You'd use this to rule out things like an erosive cholesteatoma or bony labyrinthine anomalies.
Now, here is a massive clinical pearl that you need to integrate into your practice today. You have to order both of these MRI sequences together. If you only order a T1 scan with gadolinium, yes, you might confirm active blood labyrinth barrier disruption, you found inflammation. But gadolinium alone will completely miss an active AICA stroke, because vascular labyrinthine ischemia can perfectly mimic the symptoms and the hints exam of viral labyrinthitis. Skipping that DWI sequence is an incredibly dangerous oversight.
And speaking of DWI, I want to make sure we take away this crucial safety warning about timing. If you do a DWI scan within the first 24 hours of symptom onset, its sensitivity for a posterior fossa stroke is only around 80%. Think about what that means. 1 in 5 strokes won't even show up yet. So if your patient has cardiovascular risk factors, things like hypertension, diabetes, or atrial fibrillation, and they present with acute audiovestibular loss, a negative early DWI does not rule out an AICI infarction. A neurology referral remains absolutely mandatory, and you must repeat that DWI at 24 to 48 hours. All right, Section 4, the post-meningitic pathway. This is a true race against time.
Let's shift focus to arguably the most urgent scenario we face. Imagine a patient, often a child, who has survived bacterial meningitis but has subsequently lost their hearing. This defines a true emergency known as labyrinthitis ossificans. Essentially, this is the rapid fibro-osseous obliteration of the membranous labyrinth following suppurative bacterial inflammation. It leads to irreversible new bone formation right inside the cochlea. This ossification destroys the cochlear lumen, which means standard, minimally invasive cochlear implantation becomes physically impossible if we wait too long. Just look at how fast this biological clock ticks. At just 2 to 4 weeks post-meningitis, the earliest radiological marker appears. You'll see a loss of the normal T2 bright fluid signal on a high-resolution MRI, specifically Fiesta or CIS sequences. By 4 to 6 weeks, the critical window for standard cochlear implantation rapidly starts closing as fibrosis sets in. And by 4 to 12 weeks, frank, irreversible ossification becomes completely obvious on a CT of the temporal bone. This timeline is exactly why early, high-resolution T2 MRI imaging within that first month is completely non-negotiable. It is quite literally a surgical emergency.
Let's wrap things up with Section 5, key takeaways and pearls.
So let's lock in our systematic protocol with a quick summary. These 3 points should really anchor your daily clinical decision-making when facing acute vestibulocochlear loss. Number 1, pure tone audiometry and vHIT are your absolute first-line diagnostic pair. Use them to baseline the damage and map the deafferation. Number 2, a DWI MRI is mandatory to rule out dangerous vascular mimics. Remember, you have to repeat it at 24 to 48 hours if cardiovascular risk factors are in play because early scans are only about 80% sensitive. And number 3, post-meningitic bilateral deafness is an absolute imaging and surgical emergency. You need that immediate high-resolution MRI to beat the clock on labyrinthitis ossificans.
I want to leave you with a bit of a provocative thought. If a vascular mimic, like an AICA stroke, can perfectly replicate the peripheral signs of a viral hints exam and a positive head impulse test, how do we confidently build a differential diagnosis right there at the bedside? It's a vital question, because mastering the nuances of the differential diagnosis really is the only way to ensure patient safety in the acute setting.
And that sets the stage perfectly for our next topic. In Part 5, titled Differential Diagnosis, AICA Stroke, Vascular Labyrinthine Ischemia, and Clinical Mimics, we're going to build the exact diagnostic framework you need to distinguish labyrinthitis from its most dangerous mimics. Thank you for joining this explainer. To explore more topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, please visit AustralianDizzinessClinics.com. Don't forget to subscribe and leave a rating. See you next time.